Noon, so we're going to go ahead and get started. So welcome everybody, and thank you for joining us for the Public Health Training Hui's October webinar. Today's webinar is Let's Talk Story, Advanced Care Planning to Improve Patient Care with Hope Young from Kokua Mau. Next slide, please.
Sorry, we're just getting a little bit of a delay over here. Okay. Give me 1 second. Oh, there you go.
To introduce the organizers of this training. So my name is Stephanie Moyer, and I'm the Community Initiatives and Training Coordinator for the Hawaii Public Health Institute. Also want to introduce Makamai Namahoe. You heard her speaking a little earlier. She is High-Fi's Contracts Grants and Operations Assistant. And we also have the Public Health Training Hui Steering Committee, which is made up of 14 members from various organizations. Our sponsors and partners for today, as I mentioned, the Hawaii Public Health Training Hui, the Western Region Public Health Training Center, and the Public Health Learning Network. These are continuing education credits are being offered for today's webinar in these 5 areas. We will be sending you the slides, so if you don't have time to jot down these codes, you will be receiving them. To receive credit for today's webinar, you will need to complete the evaluation that I will send upon completion of the webinar today. You'll have 2 weeks to complete the evaluation, and there's a typo on this slide, I just saw it now, but the deadline to complete the survey is going to be Friday, October 25th, so that's 2 weeks from today, and then I will be sending them out no later than Monday, October 28th. If you have not received your certificate and have completed the evaluation by October 28th, please don't hesitate to reach out either to myself or to Maka. Disclosure, the planners and presenters have no relevant financial relationships to disclose. Learning objectives for today's webinar is analyze the importance of advanced care planning for all competent individuals over the age of 18 and the appropriate documents to support wishes for care, apply practical knowledge of the proper use of advanced directives and/or providers' orders for life-sustaining treatment, and gain an understanding and confidence in initiating and facilitating advanced care planning conversations by using resources and tools presented. Our guest speaker today, I'm very excited to introduce you to Hope Young. She's the Advanced Care Coordinator for Kokua Mau. She's been providing community awareness and coordinates the Let's Talk Story program for the former Speakers Bureau. Hope joined Kokua Mau in 2017 under a generous grant from the Subski Foundation. She has worked in various capacities with seniors and the caregiving community for over 15 years. She is a graduate of the University of Hawaii, West Oahu, and has a BA in Public Administration with a concentration in Healthcare Administration. Hope enjoys being out in the community and sharing the importance of advanced care planning, and hopes to someday normalize the conversation to ensure that everyone's end-of-life wishes are expressed and honored. So without further ado, I would like to introduce you to Hope Young.
Thanks, Stephanie, and thank you, Makamai, for being over here, helping with the computers. So, my name is Hope Young. I'm from Kokua Mau. We are a nonprofit organization. We're a 501c3 community benefit organization. And our members are hospices, health plans, hospitals. We have some long-term care organizations. We have a few churches that have joined us, as well as some other organizations across the state. We have passionate volunteers. I actually get the privilege of working with 15 people who actually see the value in doing this. They are nurses, they're physicians, they're social workers. They're people who see what happens when we don't do advanced care planning well. They'll tell you about stories of fistfights in the ER, families infighting because people don't agree, and that's what we're really trying to change. So we, slight delay.
Hello. Oh,
there we go. So we have 3 areas of activities that we do within our organization. So we work with people who may be facing serious illness and their loved ones to understand the decisions they may need to make as early as possible. We provide professional networking and training, and we also we do change the system through policy and legislation. So I realize this isn't interactive, so I'm going to be throwing out some questions from time to time. Go ahead and sit and think about it. Has anyone thought about how they want to go? How they want to die? I usually put this out there, and people more than likely will say they want to go like that. They don't want to have a debilitating disease. They would rather go in their sleep or have a heart attack. Well, only 10% of the population go out like that. So the 90% of the rest of us may be facing some illness somewhere in our future, and we should be planning accordingly for that. So we call ourselves a movement, and we're leading that movement to make advanced care planning and open communication about care and support for those with serious illness and their loved ones, including end-of-life care, the cultural norm. We want people to talk about this sooner rather than waiting for a diagnosis to have this conversation. We want people to talk about it when they're healthy. It's not so scary to do this when you're healthy, and that's when we want to get these conversations started. So we do like some humor. Communicating with dead people is easy, but communicating with live people is hard. And I always get chuckles at that because it is true, right? And sure, she has the right to die. All she has to do is come out of the coma and just ask. And for those of you who can't see it, it's actually the Supreme Court saying this. Woody Allen has a great quote, "I'm not afraid of death, I just don't want to be there when it happens." I'm with you, Woody. And this is my all-time favorite. I'll give you a chance to read through it. Feel free to chuckle on your own. All right, so our goals for today is talking about the advanced care planning, the importance of it, the Let's Talk Story program, having the conversation, and then we're going to look at the documents to support people's end-of-life wishes, the advance directives and the provider's orders for life-sustaining treatment, which is also known as the POLS. So what is advanced care planning? It's kind of a phrase that people are throwing around more often, but it's an ongoing process of thinking about, talking about, writing down, and sharing your healthcare wishes. Again, this is something that we should start doing when we're healthy rather than waiting for a diagnosis, because at a time of diagnosis, that can be a scary place to start this conversation. No one knows when they might become very ill. This helps your companions, your loved ones, to find your voice, and it eases the burden for others to have to make tough choices. Now again, I'm throwing a question out there to you. Anybody planning on getting dementia? This is one of the things that we can do because we don't know when illness could happen, right? You could be walking on the street and get hit by a bus. If you have your advanced care planning in place, your loved ones have that much, they're able to speak on your behalf. It's also important to point out that in the state of Hawaii, there is no next of kin rule, meaning just because you're married doesn't mean your spouse is allowed to make those decisions. Just because you're a parent doesn't mean you automatically get that opportunity to make those decisions of an 18-year-old child. In the state of Hawaii, what they do is they call a meeting and they ask all interested parties to come together and choose somebody to be that spokesperson. Now, I don't know about your family, but in my family, the loudest person usually wins. And that person doesn't always know what I would want. So why not do this as a gift to your loved ones so that they don't have to try and fight? That's where my nurses have shared stories where people really have a hard time picking one person. This is also when a guardianship case could actually happen. If the group of people who come together to do this, to try and figure out who's going to speak for you, if they don't agree, they could have to take it to court. Guardianship, it's an expensive and lengthy process. $5,000 in probably 6 months at the soonest before you get an outcome. So this is why advanced care planning is really important for each and every one of us to do, but also for the people you come in contact with, whether they're patients or clients. It's really important for them to have their voice out there as well. So here's another, what do you do? In times of a hurricane, we do something, right? The lines go up at Costco's, people are buying toilet paper, they're buying water, batteries, filling gas. We do something, right, when we know that there's a hurricane coming. Well, the last time I checked, mortality rate is still at 100%. So why don't we do something to prepare for our own inevitability? We're going to be using the Conversation Project Starter Kit. And the Conversation Project is a public engagement campaign dedicated to ensure that people's wishes for end-of-life care are expressed and respected. It's a part of the Institute for Healthcare Improvement out in Boston, and it was developed by Ellen Goodman. Ellen was she is a Pulitzer Prize-winning writer, and this is her mother. Ellen had thought that she had had really great conversations with her mom about care, about what to do when she started to get older, but she realized very quickly that she hadn't had good enough conversations with her mom, and mom was diagnosed with dementia. So she created the toolkit, the starter kit, which was sent out to you folks earlier, the starter kit to actually help families bridge that gap so that they can come together and help support each other during a time of crisis. So when you're doing the starter kit, do it right here, right now. These are my answers. Don't consider that, oh, maybe when I'm 80 and I have congestive heart failure, this is how I'll think. Just give your answers right here and right now. This is one of the activities that we do during our Let's Talk Story discussion. We have people talk to each other about experiencing a good or a hard death, either professionally or personally, and how that may have affected you. And what we find is that people have stories. They have experiences. And it is something that we share as humans. So this is one of our activities that we do. So, because I can't see a show of hands, I'm just going to go and jump right into this. 70% of people who were surveyed by the Conversation Starter Kit, the Conversation Project, they said they want to die at home. However, 70% are actually still dying in a hospital. What's happening there? Something's not happening. There's some sort of disconnect that's happening, that people aren't getting what they want. 80% of those people who were surveyed, they say they want to talk to their doctors. They want to have a conversation about end of life. But in the state of Massachusetts, only 17% of people are actually doing that. In California, only 7% of people are doing it. 90% of people think that these conversations are important to have. And in the state of Hawaii, we did a survey a couple of years back, and 30% are self-reporting, saying that they are having these conversations. So we may be ahead of the national norm, but we still have room for improvement to have these conversations. So the Conversation Project, they have developed a bunch of great tools that I encourage you to go and look at. They have the Conversation Starter Kit, which was sent out, the link that you folks had. They also have a How to Talk to Your Doctor Starter Kit, how to be an agent and how to choose an agent. On their website, it has proxy, but if you go to our website, we have it as agent. They also have a starter kit for dementia patients and one for children with serious illness. All free to download. I encourage you to go and check them out. The conversation starts with you. So we have to think, and when you're going through the starter kit, there are questions that you need to ask yourself. Who do you think you need to have these conversations? What is it that you need to think about before having these conversations? I'm going to give you all a quick minute to just kind of sit and contemplate this question, because how do we get to the point where we know what's important to us? Here you go. Take a minute to contemplate this. What matters to me at the end of life is. The question we're contemplating right now is, what matters to me at the end of life is. Where would you be Who would be there? Are there sounds in the background? Okay, so if you have your starter kit, go ahead and open it to page 3, and you'll see a box that looks exactly like this. You can go ahead and write your thoughts in that box. Those people who were surveyed, they were asked that question. And these were some of the answers that they provided. The larger the word, the more times it was used to describe what matters most to them at end of life. Notice peaceful is right there at the top, right? With family and friends, comfortable, painless. If these resonate with you, just keep in mind that these are the things that other people are thinking about as well. Notice it doesn't say in pain. It doesn't say suffering. For the most part, people want it to be a positive experience. What matters to me, see, here are some of the responses. I want to say goodbye to everyone I love, have one last look at the ocean, listen to some 90s music, and go. Wow, if it was that easy, sign me up for that, because that sounds pretty cool. Having my sheets untucked around my feet. So I like to share that one because when my mother was in the ICU and the nurses would come in, they would tuck her feet in every single time, and she'd spend the next 10 minutes kicking her feet to get those sheets out from untucked her feet. So I finally wrote a sign and I put it above her headboard, and it said, "Please don't tuck my sheets in around my feet. I like my feet uncovered." The nurses appreciated knowing that. Mom didn't spend her energy trying to get the sheets untucked. And it really was a positive experience for the staff to know how to support mom. So you'll be hearing more about mom throughout this presentation. Some background on her. Mom had Parkinson's. She had congestive heart failure. She also had very bad arthritis, and she had some mild dementia. And when she wound up in an ICU at the end of her life, this is when I had that sign created for her about untucking her sheet around her feet. So with the starter kit, if you haven't already, I encourage you to do so as homework. There are only 9 questions on it. There are no right or wrong answers. There's just your answers. As a patient, I'd like to know, and it could be only the basics, or you could be all the way on the other side of the scale saying, I want all details about my condition and my treatment. Or you might be somewhere in the middle. Once again, there's only nine questions, pretty pain-free. It's something that if you're doing this with loved ones, everybody can benefit from knowing your answers. I had a classmate of mine, her sister was on RN, and her sister was diagnosed with stage 4 cancer. Sister had her own ideas because she was on RN. She knew what she wanted, and she knew exactly what she did not want. And so she planned her course of action. She planned her healthcare decisions. Well, the family wasn't on board with that. The family actually was having a lot of infighting. They couldn't understand why sister was deciding to do things and not trying the next approach at fighting the cancer. And so I gave her the starter kit, the one that you have in front of you, and told them to sit down as a family and everyone give their answers. She called me the next day and she said, that was the best 2-hour conversation we've had in the last 6 months. I call this a relationship builder, and it's a means of getting to learn about the people you love and what things are important to them and how you can support them. So when faced with a serious diagnosis, we say bring the starter kit out, even before the serious diagnosis. Have these conversations with each other because that's how we build those relationships to be able to support one another. Then who do you want to have these conversations with? Who's important that needs to know this information? Well, what I always say is who would show up for you? Who would be the people who would come to you during a time of crisis or serious illness? Those are the people who would benefit from knowing this information. So whether it's a parent, a child, a spouse, a sibling, maybe good friends, the people who show up, they want to be able to support you well. They want to be able to be there for you. give them the information so that they can do that. And this is a great opportunity to share your answers from the starter kit. When would be a good time to talk? Well, saying let's talk soon, that's not a time. Soon is not a time. The next holiday coming up, maybe Thanksgiving, we had Reverend Rosemary Lloyd come and visit us, and she came from Boston, and she shared a story that her parishioners, she was doing a whole month of end-of-life sermons. And it was actually in November. So she encouraged her parishioners to go out and have these conversations. And she was invited with an invitation to a Thanksgiving dinner. And on the bottom of that invitation was noted, there will be no pie till you tell me how you want to die. That was a great opportunity for the family and whoever was invited to that Thanksgiving dinner to share their ideas and their thoughts and complete a starter kit. So again, set a time and have that conversation. It shouldn't be so scary. If you're talking about it, the more you talk about it, the less scary it gets. So it's that first one that might be a challenge. Once you get started, you can learn more from each other. Another tool that I encourage you to go out and take a look at, especially for those of you who are doing advanced care planning with patients or clients, Go Wish cards are a nice starting place. They have a digital version online. They have a physical version, which are cards. Both work the same way. The Go Wish cards, the idea about it is that you have to prioritize what's important to you. And sometimes you don't really know what is important until you have that conversation, right? So for example, what you would do with the Go Wish cards is you would make 3 piles. The first pile is what's very important to me. Second pile is somewhat important to me. And the third pile is not so important. Now, before using this with any patients or clients, I encourage you to do it for yourself first. It's a great opportunity to recognize that sometimes certain things are more important than others, but it also gives you the ability to walk someone else through this. There are sayings on the cards. There's 36 cards, if I'm not mistaken. And there are things such as to be pain-free, to avoid arguments, to be financially stable for my family, to have my family with me. There's a wild card where you can actually name what you would like that to be. So for me, for example, the wild card is having my dogs with me. But you go through this and you get your top 10 of your very important. And then I encourage you to take an extra step and whittle that down to 5. I actually had my husband's uncle do this. He's got a few health issues going on, and the family, they're not all in agreement as far as what is important to him, how they should approach his health issues. So I asked him, I said, Uncle, do these cards for me. Show me what's really important to you. I took a picture of all the cards that were really important to him, and I sent it to his sons. And I said, these are the things that your dad he finds are most important. Then I took it and I showed it to his wife, Auntie. I said, Auntie, these are the cards that he said is most important for him. And she gave me this funny look. She said, that's not important. That's not important. That's not important. And I said, wait, that's not important for you, but that's important for him. And she had to take a step back and recognize that, that might be why they were fighting. So I encourage you to go and use this as another tool to get conversations started. Your next steps would be having the conversation for yourself first. As we approach this, we're approaching this as an individual who could benefit from this conversation. How do we do this well? And once we do it for ourselves and our loved ones, we're better prepared to do it for the people that we're doing it in the community. Share your stories. Build your relationships through your conversations. We really encourage you to go out there and do this for yourself first, and then help someone else. You know, when you're on the airplane, they say, in case of an emergency, your air mask will fall down. They'll drop down, right? And they tell you, if you're traveling with a child, put yours on first, and then assist the person that needs help. So again, same principle. Do it for yourself first. Because if the unexpected happens, who would speak for you? And would they know what you would want, or possibly what you would not want? And if you think, yeah, they would know, ask yourself, how would they know? The only way to know this is to have these conversations, right? So again, everyone over the age of 18 should have an advanced healthcare directive. We're not targeting certain demographics. We're encouraging everyone over the age of 18 to do this. I found going out in the community and doing these presentations by saying all competent adults over the age of 18 should be doing this, you find less reluctance in those who you think really should have them, because actually everybody should. Without an advanced directive, precious time could be spent wasted trying to designate your healthcare agent. Again, as I mentioned earlier, they pull everyone together and they try to decide who's going to be that person to speak on your behalf. Well, do your loved ones a favor. Just name a person. Name the person that you trust. There's all types of planning, and this is just one type of planning. Oftentimes out in the community, I'll have kupuna come up to me, our seniors, they'll say, I've got my estate plan done, I've got my will done, I've got my program with the songs that I'm gonna play at my funeral, I've got all of that done, and all my kids get life insurance. Wonderful, that's awesome. You still gotta get there though. How do we do this well so that when you get to that point where we need to make decisions, they're supporting you? And that comes under healthcare decisions. It could also come under legal and financial decisions, but that's where advanced care planning is. So our advanced directive, this is the version that we use on our website. It is free to download. We encourage people to download it, write it down, get started doing this. At least, if the very minimum, name your agent. We have people who they haven't really thought about end-of-life issues, but they do want to name an agent. You can use this form to just name your agent. We're going to go through it in a little bit, but if you don't already have it, can I do like a survey?
Yeah, we can do they can raise their...
Yeah, if you can raise your hands if you have an advanced directive.
Yep.
Maka will give me a count on that, and if you do, great job. I actually had a social worker approach me during one of our trainings, and she said, thank you so much for having me look at my advanced directive, because my ex-husband was listed as my healthcare power of attorney. My new husband would not appreciate that. So it's important to go back and review this from time to time and make sure that it's up to date. Remember, an advanced directive can only be done when you're of sound mind. Again, those people planning for dementia, we need to do this ahead of time. It's a two-part document. So the first part appoints your healthcare power of attorney. We also call that person your agent. I like to just refer to them as your person. It appoints your person who you're giving authority to make decisions on your behalf when you're unable to. Second part of the document actually states instructions for that agent, for your end-of-life decisions. Now, when you're choosing your healthcare power of attorney, you have to really think about it. Just because you're married to someone doesn't mean that that should automatically be your healthcare agent. Rosemary Lloyd, Reverend Rosemary, she actually made a really good point. She said, during a time of crisis, I don't want my husband having to be making these decisions while he's bedside trying to support me during a crisis. I thought, oh, that's really interesting. So she actually named someone else to be her healthcare power of attorney, her agent, her person, and her husband actually thanked her for it. So who do you trust to make healthcare decisions for you when you cannot? These are people that need to be familiar with your personal values, willing and able to make decisions for you, people who are willing to stand up and advocate, because unless you have these conversations with all the people that you love, there could be infighting. Doesn't need to be a family member, and then you want to select an alternate because what if you're in the car with that person, right? So, end-of-life decisions. These things need to take effect before that document goes into play. But the biggest one that most people come across is, I have lost the ability to communicate my wishes regarding my health care, and it is unlikely that I will ever recover that ability. When these steps happen, that's when your agent steps in. So before we go into this, I want to just go back to a story from one of my ambassadors. She tells this story, and I love it because it makes so much sense to have these conversations ahead of time before naming your person. So she completed her advanced directive, She had her husband read it, and she said, honey, this is my advance directive. These are my wishes. Can you honor this? The husband read it, and he said, no. I will keep you alive as long as medically possible. Whatever machines they can use, whatever things I will keep you in a hospital forever and ever, and we'll keep you alive. And she said, oh, that's not what I want. And so she went to her son, and she said, son, these are my end-of-life wishes. Are you able to honor? And he read it, and he said, well, okay, Mom, I got you. We're just going to pull the plug. Well, that's not what she wanted either. So she went to her daughter, and she asked her daughter to read it, and she said, can you honor this? And her daughter read it and said, I got it, Mom. There may be times when medical intervention might be helping. But if it's not helping, then we need to have a challenging conversation about what our next steps will be and make decisions based on the outcomes. That's how she found out who her person was. She had to ask if they could support her wishes. So the first choice that you're asked on there is to prolong or not prolong life. Now, if you're in the medical field, you may recognize that prolong is a weighted word, because we actually have measures to keep a body alive for quite some time, right? And that would be prolonging life. So the question is, I want to stop or hold medical treatment that would prolong my life, or I would want medical treatment that would prolong my life as long as possible within the limits of generally accepted healthcare standards. Now, as professionals, I encourage you to slow down with this choice, because this is a conversation that would take a little bit more education, a little bit more understanding to make a decision on this. People need to understand what accepted healthcare standards might look like, and that could look like the ICU. And explaining that part of it to people helps individuals to understand what this choice is really asking them. Again, these are all personal choices, but how do we make an educated decision if we don't have the information to do so? So if you're helping people to complete their documents, take your time during this session so that this particular choice, take your time through this so that there's an understanding of what that could look like. The second part is artificial nutrition and hydration. Now, here in Hawaii, food is love. We go anywhere, we share food. Home of the plate lunch, how did that get started? The mixed plate, right? People share food as a means of showing their aloha for each other. When we go through the artificial nutrition and hydration, it's important to help whomever is completing it understand what and why we are asking these questions. So artificial nutrition and hydration, of course, that's tube feeding. Mom, when she was in the ICU, she had said she would try it for a temporary time. Her story is not nearly as simple as this one. So they came in with the tube, and for those of you who don't know, it's a nasogastral tube if it's a temporary tube feeding, going up the nose, down the throat, and into the belly. So they put the NG tube in, and she immediately said, get it out, it hurts. So the nurse said, oh, okay, we'll take it out, we'll try later. The second time they came in, they actually had someone else come in to just double check to make sure that it was placed in the right place. They were wondering if maybe it wasn't placed well. As soon as they got the second time in, just get it out, it hurts. Okay. The third time the nurse came in with the tube, she said, get out of here, I don't want that. Thankfully for me, Mom was awake, she was conscious, and she was able to tell me what she wanted. But had she not been able to give me that information, I would have gone off her advance directive, not knowing that it was uncomfortable for her. It's important also to say that the patient will always be offered nutrition and hydration by mouth, regardless. They're not going to starve a patient. It's also important to say that artificial nutrition and hydration for a body that is actively dying, that can actually prolong the dying process. People say, what about for a trial period? Trial period is good to consider. The thing to remember when you're creating your documents is that at the end of the trial, that means taking it out. And people can often be racked with guilt if they have to make these decisions without any guidance, which is why we encourage people to do this and put your own words into writing so that your loved ones know that they're supporting whatever you have wanted. Relief from pain, it's also important to educate why they might have questions about pain relief and, oh, you know, when they gave the morphine, they were helping someone die. Well, that's incorrect information, but that might be anecdotal for how they perceive morphine to be. Give the information about pain, and that what the pain medication is really doing is it's allowing the body to rest. And it's allowing the body to do the process that it's going through already. And then you're also got other. So when you check that, there's more information that you need to share. Artificial nutrition and hydration, it is a personal decision and one that should be made with as much understanding and knowledge so that they can make a decision that really supports their wishes. In some cases, artificial nutrition can prolong life. There are people who live on feeding tubes and they're still able to function. In other cases, it might not prolong life and in fact may actually prolong death. So, relief from pain and other important considerations, as I mentioned earlier, pain medications to ensure comfort at the end of life, it can appear to hasten death. And that's really because it's just allowing the body to relax. It's also important to recognize that that's actually considered ethical and acceptable by most medical professionals. It's a personal decision and one that if I make it, I actually have that option to have that. Whereas if someone else is making it, they might have their own biases for why I should or should not have pain relief. Do it for yourself. It really is a gift to your loved ones so that they don't have to make decisions. So, what is important to me? What makes life meaningful? This is your opportunity to actually tell your loved ones. Tell them what makes life acceptable. What makes your quality of life good to you? This is your opportunity to say, well, if I can, as long as I can eat my steak and watch my Korean soaps, let's keep going. If I can't have a conversation with my loved ones because I don't recognize them, maybe we should stop some of these medications. It's your opportunity to really share your voice. Give your loved ones, give your agent, your person, the ability to make meaningful and good decisions on your behalf. Also share with them when you would not want your life prolonged by medical treatment. It's a good opportunity too. For this document, it must be either notarized or signed by 2 witnesses. Now, it's important to recognize that if you are doing this document as a provider, you cannot be a witness on this document. However, if you're doing it for yourself or your loved ones, then you can be a witness. Your witnesses must be over the age of 18. They cannot be your healthcare agent. They can't be your person. They can't be a provider within a facility. And one witness cannot have inheritance rights. So witnesses can be a little bit more challenging to find, especially if you're in a facility setting. Notaries also a little bit harder in a facility setting because you have to either have one come to you or go to the bank, right? That's why we encourage people to do this while they're healthy. Do it when you're healthy, update it, check in on it from time to time. Now, providers' orders for life-sustaining treatment. Before I go into this, I'm going to give you all a chance. If anybody has questions about the advanced directive, go ahead and type it in. We'll address it at the end of the session. POST. So, many of you probably have seen this. Provider's order for life-sustaining treatment, the POST. That bright green form that people sometimes have. We want to make sure that this is done well. So POST. Patients' wishes aren't always known. The advanced directive might not be accessible, and they might be a DNR, a do not resuscitate. This would be some of the reasons why we would do POST. A POST is a right here, right now medical order. It's a standing medical order. So whereas the advanced directive is a legal document, your POST is a medical standing order. It gives clear and concise information for EMT and first responders on what they should and should not do in the case of an emergency. It also helps family members to recognize that these conversations have been had with medical professionals, and it is a portable document that can go across all settings in Hawaii. Important to say that the POLS, the one that we're discussing, it's for the state of Hawaii, and it does not cross state lines. It provides direction for healthcare providers during a serious illness, and it allows for shades of gray. Whereas there used to be a bracelet just saying CPR, no CPR, now you have a little bit more information in that document to provide for providers. It's usually on that bright green form, and people are encouraged to put it in a place that can be seen within 10 seconds of an EMT entering the home. It is legal if it's not on the white form. It is still legal though. The reason for the green is so that it's easily recognized and found. This is where we want to make sure that POLS is being done well. So who would benefit from having a POLS? Not everyone should have a POLS, and we really want to make sure that providers do this well. The POLS is intended for people with chronic and progressive illness, with a serious medical condition, maybe they're medically frail, maybe they have the adamant concerns about a do not resuscitate. The question you should be asking before completing a POLS with someone is, would you be surprised if this patient died within the next year? If the answer is no, I wouldn't be surprised, then they're probably a good candidate for a POLS. A little bit of history on the POLS. It actually is something that was developed in Oregon back in '91. It has expanded to almost all of the U.S. states. This map is a little bit older, but we are now in a dark pink, meaning we have a mature and robust POLS program in the state of Hawaii. The POLS is one form. There is one form for the entire state. If you see anybody creating their own POLS, please stop them. Have them go to our website. They can download it for free from our website. The use of POLS is not mandated. So it's important if you're in a facility where best practice is to have people having a POLS, keep in mind that it's not mandated. But honoring the form is mandated. And the form actually provides immunity from civil or criminal liability. The POLS, it lives on our website at kokuamau.org. Anytime there is an update, you will find the newest version on our website. It was a grassroots effort from local providers who wanted to have something out there for the public to use. And in 2009, they voted it into law, and in 2014, they actually changed it. When it was first done, it was called Physicians' Orders for Life-Sustaining Treatment. Well, they found that all the APRNs were actually completing it, so they changed it. Now it's Providers' Orders for Life-Sustaining Treatment, and APRNs are now able to sign that form. In 2009, and I have seen some forms out there that are outdated, so if you aren't sure whether you have the right form, go to our website and update it. It starts with questions that refer to the patient itself. Who's the patient, their name, their birth date, and then there's also a HIPAA part of it. Keep in mind now, a POLS and an advanced directive, they should work hand in hand. The difference with a POLS versus the advanced directive is, one, it's a medical order, but two, it does not state who your healthcare power of attorney is, who your healthcare agent is, who your person is. There's a part on it that says to allow information to be disclosed, and there's an emergency contact on there, but that does not designate your agent. The first section, when a person has no pulse and is not breathing, I will give you a moment to think that statement through. This is the question about CPR. When a person has no pulse and is not breathing, they are, well, because I can't see you, I'm going to say it. They are dead. Is not great. So the first, do you want CPR? Do you want to allow a natural death? Now, can you imagine if that's the first conversation you're having in an advanced care planning session? What a challenge that can be, to start with that as your first question. It's also important when you're doing this portion of the pulse to give examples of what CPR really looks like. So for those of you who have not done CPR on anyone or who have not seen CPR in person, in order to be effective, you have to push this far into a person's chest in order to actually be effective doing CPR. That's about 2.5 inches. In an older person, that more than likely will entail some broken ribs. It could also puncture a lung. In an older, frail person, oh my goodness, that's just scary. In TV land, which is where many of us get our information, who are not in healthcare professions, in TV land, 80% of the time that someone gets CPR, they are off and running the next day. 80% of the time. So it appears to be very effective in TV land. However, the reality of it is CPR is not meant for the elderly or frail. In a demographic of age 70 and up, CPR is successful around 10% of the time. In a demographic 80 years old and up, 3% maybe, and that doesn't mean that they're going back to their baseline. So make sure when you're going through this conversation to acknowledge what CPR is and recognize that many people are getting their information from TV land. And so going into this and talking a little bit more about this and effectiveness really allows people to make an educated decision on what their wish would be. So again, do we want to attempt resuscitation or do we want to allow natural death? The second session that comes up is the person is breathing, they have a pulse. What would you like their level of intervention to be? So the first one, comfort measures, oftentimes is used by hospice patients or patients who really they're adamant about not going back into the hospital. Comfort measures, they will keep a person comfortable, but they're not going to do any medical interventions to try and cure what's happening. Limited additional interventions, that's when you kind of get your opportunity to pick and choose what you want, what you wouldn't want. It gives you all the medical access up until an ICU. So we're trying to keep you out of the ICU when we choose a limited additional intervention. And then full treatment, that includes everything, including respirators, including machines. It could also look like the ICU. It's a personal decision what they would want, but having the knowledge and understanding of what each of those levels of care looks like is a benefit for the person deciding to do a pulse. Now, should you choose CPR, you must choose full treatment. It's important to recognize that if we bring a person back from the death, we have resuscitated them, they must go to full treatment. We're not going to drop them to comfort measures. That makes no sense, right? However, if they say do not attempt resuscitation, they get choices. They get comfort measures, they get limited interventions, they also could opt for full treatment. And that is acceptable. A do not attempt resuscitate patient could ask for full treatment. There may be a reason, if they chose that, to have a more detailed conversation of why they would choose that, because it's not very common, but it is acceptable. Again, we're back to the artificial nutrition and artificially administered nutrition. There will always be food and liquids offered by hand. So this is the opportunity, again, to reiterate how important the artificial nutrition and hydration would be should there be an emergency or a case where it might be needed. There's also an opportunity to write in there about additional orders. Then there's the signature box. You're looking at the provider, which is either the physician or the APRN, And then you have the patient or their legally authorized representative, which should be their healthcare power of attorney, their agent, their person that is designated on their advance directive. That is their legally authorized representative. Oftentimes we'll see that granddaughter takes grandma to the doctors, and because grandma has a little bit of dementia, doctor will refer to granddaughter and say, oh, here, sign this. That's not really good practice. It should be the healthcare agent. It shouldn't just be the person who happens to take the individual to the doctor appointment. You also have the parent of a minor, and yes, these forms can be done on seriously ill children. It can be a patient-designated surrogate. So that would mean the patient designates someone in front of the provider and says, my daughter has the authority. That would be when the daughter can sign as a patient-designated surrogate. If it's a surrogate selected by consensus of interested persons, that's when the group of people must come together and decide who's going to be the legally authorized representative. Or it can be the guardian. Now, it's important to point out that a patient-designated surrogate may act as the person doing the decision-making, but a non-patient designated surrogate, they actually have limited abilities on what they can do for the patient, what decisions they can make on behalf of the patient. Again, reiterating the fact that we should be giving our loved ones the ability to be there to support us and not do infighting by completing your advance directive so that they don't have to try and figure out who should be speaking on your behalf. If it's a surrogate and it's a non-designated surrogate, meaning the consensus has come together and they've elected someone to be that person, that non-designated surrogate, does not have the authority to remove feeding tubes. They actually have to get 2 doctors to agree about withholding artificial nutrition and hydration. So rather than trying to go through all of these harder steps, let's go upstream and do our advance directive so we actually have a person that we have designated to be our agent, to be the people that we trust in order to make these decisions. Which is why if your patient, if your client has a pulse, encourage them, really encourage them. If they have capacity, encourage them to do the advance directive so that they have an agent, a decision maker that can support their wishes that are on the pulse. Shouldn't be one or the other. They should be working together. Some practical considerations for the pulse. Again, the white copy is legal. The line agreement is recommended so that EMTs have an easier time of finding it in the case of in emergency. A copy of the pulse is also legal. So let's say this person has a pulse, their lime green one lives on their fridge, but they want to go out into the community and do things. Well, a copy of the pulse in the purse has been heard of. It's important to remind people, though, that even though you have a pulse in the purse, EMTs, should you collapse, are not going to be looking at your pulse. They're not going to be looking for your pulse. They're going to attend to whatever the emergency is and get that person to the hospital. Where at the hospital, they may go and look for the pulse. But EMTs, first responders, that is not their first obligation. It is to maintain the welfare of the person who's had an emergency. So we recommend that people put it on the refrigerator, on the bedroom door, on your medicine cabinet. Do not put it on the inside of the back of your door. That can be a challenge for EMTs to find. Usually when they come into a situation, the door is open, right? So we don't want the pulse on the inside of the back of the door. We want it someplace where it can be easily found. If they have a pulse and an advance directive, get a plastic sleeve that they can put it in so that they can actually get a plastic sleeve that they can put it in so that they can take the pulse and the advance directive to the hospital with them. There we go. So here's a quick, the differences between the advance directive and the pulse. Advanced Directive, again, it's meant for anyone over the age of 18. All competent individuals should be completing their Advanced Directive. It identifies wishes for future healthcare decisions, and it appoints your agent. It appoints that decision maker, that person that you are comfortable and confident can advocate on your behalf. It does not translate into actionable orders for EMTs. And CPR and your do not resuscitate status is not included on that. Now for the pulse, it is meant for anyone facing a serious illness, anyone who may have a call put into EMTs. They may require assistance from first responders. It indicates current treatment decisions. It also are actionable orders, so EMTs can honor that. And it includes information on CPR and your DNR. So where does the pulse fit in? When should we be having these conversations? Well, again, we want to have these conversations starting early while people are healthy. Start talking about it with your adult children. When they turn 18, they're going to be going off and doing whatever they're doing. That's a great time to start having these conversations. 18, let's do your Advanced Directive, so in case of an emergency, we can get information. As you get older, we're going to update the Advanced Directive. As things change, as spouses change, as friendships change, we want to go back and review it. Update your Advanced Directive periodically. Go back and check, make sure from time to time, review it, make sure it's still who you would want and it's still what you would want. So these things can change, right? Then if someone is diagnosed with a serious or chronic illness, that's when we consider bringing in a post and completing a post, and that's how we ensure wishes are honored. So if you have a patient or client who already has a post, it is a good opportunity to review it with them. Review whatever clinical conditions and changes that they may be facing with. Review what the goals for care are. It's also a good way to recognize that the patient has hopefully had a conversation with a provider and understands what they've been asked to do. Now keep in mind, if a person wants CPR and is okay with being a full code, they do not need a post. I'll say that one more time. If they want CPR and they are okay being a full code, they do not need a post. That is because that is the standard medical practice, to initiate CPR and full medical treatment, full code. So you can change, modify, you can do this as many times as possible to change your direction. Mom, in the last year of life, she actually did 3 polls, and it actually changed depending on who she was with. Not the best of things to do, but it was changed however she wanted it. The first pulse that she did, upon completing the second one, the first one should be voided or thrown away, taken out of the plastic sleeve. They're going to be looking at the most recent document. You can revoke the pulse at any time. An individual with capacity still has the authority to make decisions on their own behalf. So whereas mom, when she said she would try the tube feeding temporarily, because she still had her capacity and her decision-making authority, she was able to say, no, I'm not going to do that. It's good to remind people that they will always have authority to change it if they have the ability to communicate their wishes. So it also, the legally recognized decision maker can request changes depending on condition change or new information regarding patient's wishes. Post is more than a form, and it should be treated as such. There should be meaningful conversation that goes into having a post completed. It should really complement the Advanced Directive. So if you have a post and an old Advanced Directive, encourage an updated Advanced Directive. Because the Advanced Directive can help decision-making understanding. However, the post is only looking at 3 things, right? CPR, level of care, and artificial nutrition and hydration. And if you've been a caregiver for anyone, you know that those are not the only things that will be asked of a person who has the authority to make decisions. Again, it's not a checkbox form. it should help to guide the care. It's also an opportunity. If a doctor is bringing out a POLST form and saying it's time for a POLST, one, I recommend people, if they don't have a diagnosis, to question the doctor's motivation for bringing a POLST into the conversation. Physicians are required to go through a list of things on a wellness visit. And one of those things are advanced care planning conversations. Some have found that the POLST form is an easy 3-checkbox document that gets them to check that box off their list of things to do. We really want to get it to the point where the community recognizes that POLST is not meant for everyone, and that they are encouraging doctors or challenging physicians to have that advanced care planning conversation rather than hand a POLST. We've had people tell us that I went to my wellness visit, they gave me this green form, and they said the next time that I come back, we'll fill it out. That is not good advanced care planning, and we're trying to discourage that type of approach. We also want to say that when a POLST is coming into play, it's an opportunity to educate on palliative care and hospice. It's an opportunity to educate what those two are and how they can actually support the patient. And it gives the ability to say, instead of what's the matter with me, what matters to me? So for those not familiar, palliative care is becoming a very well-desired type of care. It's called different things by different organizations, so it's important to recognize what it is. Insurance companies, they have different names for it: supportive care, concurrent care. The idea is that palliative care, it's an integrative approach for loved ones and for the patient and their loved ones who may be facing a serious illness or have complex health issues. So it's a team approach to providing supportive care. We find that palliative care is often provided by hospice, and that's because they were developed to provide a team approach type of care. But it can get confusing to an individual who doesn't understand what the difference is. Palliative care can continue with curative treatment, and it's important to recognize that palliative care can be temporary, helping someone through an illness, but it also could be a segue to hospice at the end of life. It's a team approach where there's a physician, there's an RN, there's a social worker, and there may or may not be other providers involved, maybe a dietitian, maybe an aide. They're involved to provide support for a patient who's facing serious illness. And that support extends to loved ones as well. That helps support the caregiver during this time of crisis. Hospice. Now, hospice is wonderful. If you're familiar with hospice, yay. If you're not familiar with hospice, hospice is meant for people to have support at the end of life. Patients must have a diagnosis of 6 months or less to live, and they can get all these benefits. Now, the thing to mention is that doctors they're not always good on prognostication. They might say you have a life-threatening, life-limiting illness, but they can't put a date on it. That's why we say, ask about it. Hospice is happy to come out and do interviews and make sure that the person qualifies for hospice. Hospice is a Medicare benefit, and we want to get people referring to hospice earlier. When I say hospice, I'm guessing the first thing that comes to mind is death. I've done that survey question out there in the public, and that seems to be the relatively safe answer that people use. Hospice is related with death. However, it's important to point out that people with hospice actually wind up living longer than without hospice in place when they bring it in early on. My mom, when she was in the hospital and the ICU and hadn't eaten in days because she couldn't swallow her Parkinson's meds, which meant she couldn't take anything in, which is why she had to try and use the nasogastric tube. She kept saying she wanted CPR. And for me, that implies that she wants to try and do everything to try and continue life. but she hadn't eaten in a few days, and she stopped with the tube feeding. So I broke it down for her. Mom was a school teacher, and I told her, I said, Mom, you've been invited to the Cool Kids Club. And her eyes got really big. She said, what's that? So the Cool Kids Club, you get your own doctor, you get your own nurse, you get your own social worker, you get your own spiritual advisor, you get an aide. All 5 of those people, that's your team, that's your care team. And you get that in the Cool Kids Club. And her eyes got really big, and she said, I want that. Awesome. When I was talking to the doctor about hospice, before I introduced the Cool Kids Club, I was hoping that the doctor, the hospitalist, would introduce the idea of hospice. But he seemed to be kind of struggling with the wording. And so I had to kind of prod him along and say, is this time to talk about hospice? And as soon as I brought up hospice, he looked like he was visibly relieved. And he said, oh yes, this would be a great time to talk about hospice. Again, if you know it's an appropriate level of care, introduce it. Not all providers are comfortable with talking about hospice. So sometimes we have to ask for those benefits. Likewise with palliative care. Sometimes we have to encourage that conversation and encourage the idea that we're open to considering what other things out there are supporting us through a serious illness. So Mom, she jumped on board with the Cool Kids Club. And we had some great providers providing care for her till the end of life. Okay, so for those of you who haven't heard of palliative care or where you can provide it, right now we're sitting in the Queens conference room. Queens actually has an outpatient palliative care program for oncology patients. It's important to recognize that it's not just for oncology patients. People with congestive heart failure, people with COPD, people with dementia, people with serious illness who have or maybe don't have a pulse in place could benefit from palliative care. There was a bill recently passed that we helped work through legislature to provide palliative care as a benefit. Palliative care is getting a lot of momentum, and we encourage you to learn more about it and who's providing it. And if you have someone who could benefit from it, we have you calling hospice or their insurance providers so that they can get referred to a palliative care consult. Anyone who's recently diagnosed with something, we are encouraging the public to ask for a palliative care consult. We are also encouraging people who are completing their advanced directives to write in there, I would like a palliative consult. I would like hospice if it's at the end of life. If that is their wishes, that gives one more added caveat to the decision maker to know in which direction should we take the care. Okay, so I'm a little bit early, but I'm sure we'll have some questions.
Yeah, we actually have a bunch of questions.
Okay.
So folks, if you have any questions for Hope, please feel free to put them in the chat as well as the Q&A box located at the bottom of your folks' screen. So a couple questions that came up and popped up earlier in the session. Someone had asked, wondering what role does a patient's religion play in this discussion? Would a pastor be able to attend to help facilitate this process?
That's an interesting question, and thank you. We are trying to get out there and talking to churches, to pastors, to chaplains, to people who are in the faith community. We realize and we recognize that people are having these conversations in safe spaces. So oftentimes that's in their church. It's where they feel comfortable. You can have that conversation with your faith leader. However, some do it better than others. And it's important to recognize that. Some of them have more experience with it, and that would be what you would want to look for and ask. Mm-hmm. If we're doing these documents, how comfortable are you with having these conversations?
Awesome, thank you. We had another person just kind of give a little bit of an anecdote. She said they've had people ask if they can have more than one primary agent. For example, a patient may have three children, and she wanted all 3 of her children to work together to make decisions for her and did not want to choose only one as her agent. So they all had equal say. Is that possible?
It's possible. I would say for that individual who's choosing to do 3 agents, to recognize how well do they get along, how well can they come to a decision together. And usually if it's a parent doing it for their kids, they recognize whether or not they can come together. And also to recognize that maybe one of the three might not want to be involved in the decision-making process. So it's a good, you can do it, but the idea is to make sure that it's done well so there's no infighting.
Our AHCDs are more of a guideline. Can the name agent make decisions different than what is needed?
So this is a really important question. The advance directive, the person you name as the agent, they can do whatever they choose, which means you really have to pick an agent who is going to honor and respect what you've asked them to do, because they do have the authority to change it. If you are incapacitated in a way, your agent has the same authority as yourself. So they can actually do something other than what you've asked them to do.
We had another person ask, food is love in many cultures. For this reason, there are families who see withholding artificial nutrition as cruel and or starving their loved one to death. How best do you explain this as a form of life support and prolongs, how do you best explain this is a form of life support and prolongs the dying process?
Well, see, this is the challenge. First off, if there's no advance directive done, and this is a decision that people have to make for themselves, you really have to recognize at what point is this no longer being helpful for the patient. And that's really what you have to go with, is not just, when we come to the table, we come to the table bringing our own baggage with us, right? So our opinions about food and nutrition, and yes, food is love. Here in Hawaii, food is absolutely love. So what does that mean if I'm not giving grandma the artificial nutrition? And at what stage is she at when we decide not to have it? It's a deeper conversation, and one that we really encourage people to have upstream so that they're not facing that in that time of crisis, which is really what our movement is about, is how to get that good information out there, how to get people talking about it before they're faced with that crisis. In the middle of that crisis, it's really hard to have that conversation and be effective if they already think that I'm starving grandma. So that's really part of the big movement that we're trying to do, is get people talking about this ahead of time.
Someone had asked, are advanced healthcare directives transferable out of state?
So I would recommend, if you're going out of state, to do one for whatever state you're going to. However, it's a good starting point. And it will usually be recognized that this document states your wishes. So let's say you're on vacation. It's a great starting point. That advance directive is done. They have a point of contact. It's in a different state, but more than likely they'll be recognized as the authority because they've already been designated on a document.
Can hospice be included into the advanced healthcare directive, asking the patient if he or she would want hospice services if warranted? Some folks this person had said that she finds that since it is not addressed or the patient forgets to add it into the directive, then family members have issues with hospice. Is there a reason that it cannot be added?
There is no reason it cannot be added. In fact, we are encouraging people to add it.
Hey folks, I mean, if I guess questions are coming in, but if you have any questions to ask Hope, please feel free to add them or type them into the Q&A box or the chat box. Some folks are saying thank you for your presentation, concise presentation. Oh, I saw one. Is the post generated by the treating physician, or can the patient's person request a post from the physician?
So if it's a person without capacity and they have an advance directive that names a healthcare power of attorney, that person can initiate a post. That person can sign as the legally authorized representative on the post. So it is important to say that, yes, someone else can initiate the post. Some physicians, they really like the post as a form of advanced care planning. We are encouraging them to do it according to the diagnosis, making sure that it's an appropriate use of the form. But absolutely, if you're a caregiver and you think that your person could benefit from having a post, you can ask for it. While she's looking at questions, you see our resources up there. We do have free training that we provide for individual groups, organizations, churches. If you know of any groups that might benefit from that, feel free to let us know and have them request for a Let's Talk story. The session that we had today was a little bit more in detail for professionals. The one that we do out in the community is a little bit slower process. So we encourage you to have them contact us. We also have these documents translated into 10 different languages. The top 10 languages spoken in Hawaii. All of these are translated. If you have an individual who's using the translations, make sure that they complete the documents in English. But all this information is provided in 10 different translations. Here's my contact info if you want to reach me. Again, everything on our website is free to download. We encourage you to use the tools, the Conversation Starter Kit, as well as the Go-Wish cards in order to facilitate meaningful advanced care planning conversations.
Someone had asked, can a packet of 36 cards be provided to hospitals in the region? They seem to provide more information than a advanced healthcare packet.
That's an interesting way of approaching it. I think facilities would need to decide whether or not they'd like it. I know that whenever I've gone out and done it at facilities, usually the director really, if they like it, they really draw to it. I've had organizations go out and buy the cards because they just see how much easier it is to facilitate the conversation. So.
Oh, sorry, I missed this one earlier. Someone had asked if you can clarify which copy needs to be two-sided. What form needs to be two-sided?
The two-sided post maybe is what we're talking about.
Mm-hmm.
So the post is the green form. It's two-sided because, and actually you can do it in two copies. It doesn't have to be two-sided, but there's the idea that the signatures are on one side and then the emergency representative, the emergency contact is on the back, or if it's a designated surrogate or a non-patient designated surrogate is on the back.
I have one. Can these forms be, like, if they're laminated, are they still considered legal forms? I know it's certain documents, once they're laminated, they're no longer considered legal. Like a Social Security card, I know that you can't laminate it or else it's not considered acceptable. So I'm wondering if these forms, can they be labeled and are they respected if they happen to be labeled or whatnot?
I would say they'd be honored. The thought with that, though, is what if they want to make changes? So if they want to make changes later on down the line because of a change in diagnosis, a change in expected outcomes, then you're going through that lamination process all over again. A better option would be to put it in a plastic sleeve alongside your advance directive. So it's still protected, but it's a document that they can pull out, they can look at, they can change as needed.
All right, folks, any other questions for Hope? A lot of folks are really appreciative, and I think it's an excellent presentation.
Well, thank you.
Okay, there's one. What's the best way to find a notary who speaks a specific language if the person does not speak English and does not have two witnesses?
Ooh, that's a challenge. So I would say call the notary office. They may have a list of people who are bilingual. I can tell you that some languages would be harder as a challenge in general. With the notary, they don't have to speak English in order for me to notarize their documents, but they do have to have their ID, and the document needs to be in English. So when I notarize, and I am a notary, when I notarize, I'm looking at the ID. This is the person who has made a signature on this form. That's all I'm notarizing. So the only reason you would actually need a bilingual notary is if the forms are not in English.
Awesome. Okay, well, I will spotlight that to Steph. Mahalo, folks, for all your questions. All right, Steph, you are on.
All right, thank you again.
Great, thank you again.
Is it better now? No.
Is it better now?
Are you guys hearing the echo up there, Mata?
Are you guys hearing the echo?
Nope,
Okay.
it's all, you're great.
I'll turn
Sounds coming in
myself
great.
down on my own computer. Sorry about that. just want to mahalo all of you for joining us today. Mahalo to Hope for her wonderful presentation. Just a few reminders before we go. I will be emailing out the link to the evaluation by this afternoon, and our evaluation will be available until October 25th. At that point, the certificates of attendance will be sent out to all of you. We didn't mention in the opening that if you are seeking continuing nursing education credits, you do have to complete the University of Arizona evaluation. And the password for this is ADVANCE with no D. So ADVANCE, ADVANCE. Another reminder, we do not have a webinar next month, so nothing in November, but please save the date of Friday, December 6th for our December webinar. We are still finalizing details on that, and we'll be in touch via email to let you folks know about that. So again, mahalo, and we'll see you in December.